All right, today we are diving into something that pretty much anyone who's active has worried about: ligament injuries in your legs. We're going to get into the nitty-gritty of how clinicians figure out exactly what's gone wrong.
You know the feeling, right? Whether you're playing a sport or you just step off a curb the wrong way, there's that sudden, sharp moment. That's often where the story of a ligament injury begins. So let's talk about what happens next.
And believe me, this is not some rare thing. Just take a look at these numbers for high school knee injuries. The MCL, that's the medial collateral ligament, accounts for a whopping 38% of them. And the ACL isn't far behind at 25%. It just goes to show you how incredibly common these are.
So where are the usual suspects? Well, we're going to focus on the two main hotspots: the knee and the ankle. That's where most of the action happens.
Now, you hear a lot about knee injuries, for sure, but it's actually the humble ankle sprain that wins the prize for the most common injury. Not just in sports, but everywhere. It's the #1 reason people show up in emergency departments with this kind of issue. It's an absolute classic.
Okay, so how does a doctor or a therapist figure out what's going on? Honestly, you can think of it like a detective story. And the very first step is to gather the evidence, which all starts with listening to what the patient has to say.
This part is like taking the witness testimony. The patient's story gives you all the initial clues. Asking, how fast did that swelling come on? Or could you walk on it right away? The answers to these questions are what allow a clinician to start building a theory, an initial hypothesis about which ligament is hurt and how bad it might be. This conversation is the bedrock for the entire diagnosis.
So once you have that initial idea, the investigation moves on to the physical exam. This is the forensic analysis, and it's a really systematic 4-step process. You start with just looking, and then you move through these steps to either prove or disprove that initial suspicion.
Now, one of the first things a clinician is looking for is something called articular effusion. It sounds technical, but all it means is swelling that's trapped right inside the joint capsule. And knowing if that's happening is a huge clue.
And this is where it gets really interesting. Just by looking at where the swelling is, you can get a pretty good idea of what's injured. See, if it's an ACL tear, that's a ligament inside the joint, you get that contained swelling, that articular effusion. But with an MCL tear, which is outside the joint capsule, the swelling is much more spread out and diffuse. It's a classic giveaway.
The next step is palpation, and this is not just random poking around, not at all. It's a really skilled, systematic search. A clinician who knows their anatomy will literally trace the path of the ligament, feeling for that one exact spot of pain. It's all about zeroing in on the damaged structure.
All right, so once the injured ligament has been identified, we get to the climax of the investigation, figuring out just how bad the damage really is. This is where we start grading the injury.
This chart right here, this is the playbook. So a clinician does what's called a stress test, where they gently move the joint to test the ligament. And they're feeling for two main things. First, laxity. Is there more wiggle than there should be? And second, the end feel. Is there a solid stopping point? With a grade 1, it hurts, but there's no extra laxity and a nice firm end feel. A grade 2, okay, now we're feeling some extra movement, but you still feel a solid stop. But a grade 3, that's a different story. You get significant laxity, and there's no firm end feel at all. It just feels mushy, like the joint could keep on going.
And this really says it all. At the end of the day, that hands-on ligament stress test is the single most important tool. It's how you diagnose the injury, and just as critically, how you figure out how severe it is.
But listen, the story doesn't just stop once you have a diagnosis. For a lot of people, that initial sprain is just the first chapter in a much longer book. Let's look at what can happen down the line.
Just look at this number for a second. Somewhere between 40 and 70% of people who sprain their ankle once will go on to have it happen again and again. This is really a one-time thing. It can kick off a whole cycle of problems.
And this cycle has a name: chronic ankle instability, or CAI. It's exactly what it sounds like. Repeated sprains, that terrifying sensation of your ankle just giving way, and a general feeling of wobbliness that just doesn't go away.
And CAI isn't just a feeling. It causes real physical problems. People often have trouble with their balance. They lose proprioception, which is your brain's automatic sense of where your body parts are. On top of that, they can lose range of motion and develop muscle weakness not just in the ankle, but all the way up into the hip and knee.
And this isn't just an ankle problem either. The same kind of thing happens after major knee injuries, like an ACL tear.
You can end up with long-term instability and a much higher risk of developing arthritis in that joint later in life.
Which brings us right to our final thought. That initial diagnosis, that's great. It solves the mystery of what happened. But for the person living with the injury, is the story really over? Not by a long shot. That's often just the start of a whole new journey.